Go ahead.
All right, awesome. Good morning. Welcome to Packard Grand Rounds. We're very excited to have everyone here. This is the era of COVID Grand Rounds, and so we'll be continuing our series addressing the various challenges that COVID has brought to us. I'm Lisa Chamberlain, Associate Chair of Policy and Community Engagement, and will be filling in for Mary Leonard today in moderating this conversation. So I want to tell you a little bit about what's coming up. On May 1st, we'll be hearing from Dr. Natalie Pagler about telehealth in the era of COVID-19. She's been leading the charge there and doing an unbelievable job, dragging us all into the future. So looking forward to hearing about the evolution there. Next week, looking forward to hearing about one of our patient safety lectures, Improving Safety Around Central Venous Lines. That's going to be a conversation between Lisa Bain, Thomas Caruso, Shelley Josephs, Andrew Palmquist, and Andy Shen. So we'll be looking forward to that. Today, going to focus on education in the time of COVID. And that conversation today is going to be led by Becky Blankenburg, Haley Gans, and Carrie Rassbach. So I'd like to go ahead and introduce all of them. So then we'll hand things over to Becky and get started. So Dr. Becky Blankenburg is a clinical professor in pediatric hospital medicine and associate chair for education for our Department of Pediatrics. Haley Gans, also clinical professor in pediatric infectious disease, so fairly busy service right now. Thank you, Haley. Director of fellowship education for our department. And Carrie Rassbach, clinical associate professor in pediatric hospital medicine, the program director for our pediatric residency program, and the combined pediatrics anesthesia residency program. So I'm going to hand things off to Becky to get us started. And as always, please do go ahead and text in that code so that you are sure to receive your credit for CME. So.
Thank you. So thank you again, Lisa, for introducing us. And I really just actually want to take a moment to thank the organizers and for Mary for prioritizing all of these grand rounds for us. I also wanted to really thank Becky for envisioning this and inviting Carrie and I to collaborate with her. This is a very exciting topic for us. I want to thank you all for joining us today, and please chat with us in the chat box, which we would love to hear from you and hear your comments so that we can make sure that we address things that you're thinking about. And I really want to thank everyone for their commitment and dedication in this times of stress, and really the innovation that we've seen to continue to train our trainees and provide a learning climate that's as optimal as it can be has really been inspiring, and we really hope to be able to provide some highlights of that today for you. And especially we want to just thank our trainees for their commitment and dedication, their bravery during this time, and they've really taught us a lot. So with that, I will continue on. We have no financial disclosures. We thought we should tell you that Becky Blankenburg is the president of the Association of Pediatric Directors and is on the board of the Federation of the Pediatric Organizers. And I am a member at large of the APPD, which is the same organization as above, Fellowship Directors Executive Committee. I should also let you know that we are very passionate about medical education, as a full disclosure. The objectives that we had put forth today is to identify how COVID pandemic is affecting the learner's professional identity formation. And we also would like to highlight the interactive teaching, role modeling, reflection as ways of improving learning. We want to explore the impact of a pandemic on clinical training and discuss creative ways to mitigate these negative effects, and to identify causes of healthcare provider stress related to the COVID epidemic and methods to manage this stress. And lastly, we'll be discussing some of the national educational policy changes that impact our learners. Next slide. As a way of background, we want to let you know that we have actually learned a lot by our contact with the learners and educators across Stanford in our GME office, and also our colleagues around the country, including all the national organizations that you see listed there. Next slide. We thought we would start with some testimonials, lessons learned from some trainees. There was an element of fear or worry, especially at the beginning when information was so limited and changing by the hour. However, the administration was very truthful about the extent of the knowledge. That was reassuring, and just really this testimony focused on the ability to just discuss was a way of making them feel more confident. I can recall having a few emotional breakdowns. One of the biggest parts was the change in the atmosphere at work. It became a high level of anxiety for the nurses, for the patients, when a lot of our colleagues were sent home. And lastly, I think as part of the medical profession, this is a very principle of why people are in medicine. Whether you're a nurse or a doctor or a front desk clerk, you choose their profession for a reason, and is tested like this in SARS. It really is true why medicine was once, or even now, considered by some to be a noble profession. I think these sentiments, while you can see that this was a qualitative study that was done on medical students, impact from the SARS could really be something that could we could just put COVID as a substitution there, and these sentiments are something that could have happened. But what I want to point out today is that we can do things differently. We have learned from some of the past, and we also have been fortunate to learn from our colleagues who were impacted before us. And so despite the fact that these testimonies showed that SARS had an impact on medical students and concerns about their personal safety, it had a negative impact on patient care, house staff education, and emotional well-being. We have learned from this, and we hope to share that with you today. So I'll hand it back to Becky.
I'm excited to talk with you now about the effects of COVID on education. We've found a number of unique educational challenges in the COVID-19 era. Many of you may be aware of the clinical challenges with decreased patient volumes pre-surge, where many clinics and elective cases have been canceled, and we've been seeing decrease in patient volumes as well. In addition, there have been decreased numbers of providers allowed to physically examine patients due to the need to preserve PPE. And we've seen a conversion to telehealth. There are some parts of the country where we've seen too many patients during the surge, and providers have been reassigned to clinical areas they are unfamiliar with. Fortunately, this has not been true here at Stanford. Meanwhile, due to sheltering in place, we've had an inability to come together for teaching sessions. Many institutions have canceled their teaching sessions. I'm very proud to say that Haley and Carrie have led us here in transitioning our teaching conferences to video conferencing. In addition, some other unique challenges are that it's a stressed educational system. With fewer teachers available, clinical educators have been pulled to clinical work and to increased meetings. Both teachers and learners are being asked to do things that are outside of their normal teaching skill set. Prior to this, many of us were unfamiliar with video conferencing as a teaching methodology and telehealth. Many learners' research plans have been impacted, and there are worries about learners meeting graduation requirements. In addition, there are profound effects from isolation, anxiety, and depression. We think most importantly, however, the largest educational challenge is really the effect on learners' professional identity formation from changes in the learning environment. We think COVID-19 in both negative and positive ways is having a profound effect on learners' professional identities. Let me share a little bit more about what professional identity formation is. This is a conceptual framework that is known and loved by many of us that brings together professional identity formation and socialization. It was developed by Cruz et al. In 2015. And basically, it stipulates that we take our existing personal identities, and through the process of medical education and health professions education, we are influenced by a number of factors that really help develop our both newfound personal and professional identity. Many people initially thought this was only during formal training periods, but we actually believe this is a lifelong process and that COVID-19 is having a profound effect on how many of us view ourselves both professionally and personally. Throughout this talk today, we are going to focus on these different areas and what challenges exist and also what opportunities exist for us as educators. I will be focusing on the formal teaching, role models and mentors, and the learning environment. Dr. Haley Gans will be focusing on the clinical learning environment and the healthcare system and our clinical experiences. And Dr. Carrie Rassbach will be focusing on a number of issues related to wellness, including family and friends, isolation from peers, and the effect of symbols and rituals, including things like the white coat ceremony or graduation and how those affect our professional identity formation. So to speak a little bit more about things that we can do, let's take a moment now, and I would love, this is an interactive moment where you can engage through Poll Everywhere. You can either log in through the website or log in through texting on your phone. If you text to 22333 and write "ready to learn," then you'll be able to answer this question. And or if you go on the website, the Poll Everywhere website, that's listed there. And please share what methods can you use to teach during a pandemic or any time. Great, and we're beginning to see some answers come through. So learning modules, Zoom, WebEx, email. I love this. What a great group of educators. I am continually learning from you. So narrated, the idea of narrating your modules, self-reflection. We love self-reflection. Phone. Look at this. You've come up with many different ways that can continue to adapt to this new learning environment. And I think this is what we've been most struck by with COVID-19 was how quickly a system that was set up in a very different way has quickly assimilated to new ways of learning and teaching. Excellent. I want to share with you some of the ways that were discussed in a recent, this is a recent perspectives piece by Robert Chick et al. In the Journal of Surgery. And these methods, though put forward for surgical trainees, I think apply very well to pediatrics. They included video conferencing, online cases, articles, board review questions, involving learners in telemedicine clinics, which we'll talk more about, procedural simulation, and the facilitated use of procedural videos. And this last one is the idea that you take videos of a procedural case or a surgical case, and the learner will talk you through the steps that they would be taking, including any concerns about possible risks and benefits and missteps that can take place during a case and what they would do in those moments. So we want to speak a little bit about how do you use interactive teaching using video conferencing. So Zoom, which we've become very familiar with, has many interactive features. The chat function allows learners to share ideas and to ask questions as the teaching session is going along. It's great to have someone who's running the chat, as Dr. Chamberlain is for us today, to bring forward any questions that arise or comments that arise. You can use a small groups feature that allows small groups of individuals to discuss and then come back to the larger group. This allows for a more discussion in depth with a smaller number of people. Again, I would recommend having a facilitator in each group or at least a very specific prompt. And then you can use a whiteboard feature. This was a recent morning report that one of our senior residents, Dr. Christina Turn, ran, and it was to discuss how do you do end-of-life discussions. And she did a beautiful job in this large group. You can see many of our residents on the screen, and there were many more on the additional screens. She had done a role play of how to do an end-of-life conversation. And following that, we got into small groups, and this was a small group of residents where we had a great discussion about what worked and what didn't work in her role play and how we might do it better. So now, great, I see you're already answering questions ahead of time. What a great audience. Prior to COVID-19, I'm curious how many of us had taught using video conferencing, using Zoom, WebEx, BlueJeans, etc. And please feel free to add in your answers. A is no, I didn't realize it was meant for anything but meetings. B, no, I thought about it but never had. C, yes, but I didn't feel comfortable. And D, yes, it was great. I will say, so I see a vast majority of us never had taught via video conferencing. I had never taught via video conferencing prior to this, and I continue to learn a lot in each and every interaction, and encourage you to use these different functions to make your teaching more interactive. So Poll Everywhere, which you've just been seeing demonstrated, is a great way to involve the audience. We're lucky here at Stanford because with your SUNET ID, we all have access to the Poll Everywhere that pulls it automatically into our PowerPoint presentation. There are great options for multiple choice questions, word clouds, and brainstorming. I just wanted to talk a moment about role models, mentors, and reflection. We believe that role models, mentors, and reflection are key for the professional identity formation of our learners. And this, as we talked about, is such a crucial time for all of us figuring out our identities in this new pandemic. Though there's been a lot of research done on role modeling, and though many of us may have thought that it just naturally happens, there's actually an art to role modeling. There are 3 components of role modeling, and I encourage you to use these. Priming before, which means that you alert your learner to what they're about to learn. This may take place in a clinic. If you're going in to see a patient with a fever and respiratory distress, you might talk about the differential, or you might talk about the 3 key questions that you would want to know. This can be prompted to the learner so they have an opportunity to put forward what they're thinking, and then you can help amend that prior to entering the learning experience. It can also happen in a high intensity situation like a code. One time when I was running to a code with a medical student, I had them solely focus on how is this code being run, really trying to emphasize the point that it really helps to have a team leader. The next step is thinking out loud during this situation. Our learners have really highlighted that if we think out loud, that there's so much more that we can all learn together. This may come about in a procedure or a surgical procedure or otherwise, as you're thinking through the steps of the procedure and thinking about what comes next and why you're taking the actions you're taking. It can also come through thinking through a differential and why you might put one diagnosis higher on the differential than another. Finally, there's the step of debriefing. I'd really like to highlight this. There are times teaching that I haven't had a moment to prime my learners ahead of time, nor think out loud during this situation, but there is always time to debrief a situation afterwards. Debriefing allows the learner to reflect on the situation and to learn and to apply it to their own scaffolding and their own learning. It allows you to be able to help correct any mistakes, either in yourself or in others, and help guide all of us to being better learners. Finally, I'd like to talk about the learning environment. During this pandemic, the learning environment has become quite restricted, and we're actually extremely concerned about how integrated our learners can be in the learning environment, and think it really behooves all of us to think about how do we bring our learners back into the learning environment. We need to integrate them into this new learning environment, both in person and online. And why? This is critical for learners' professional identity formation. Being excluded from the learning environment at a time when we are having a national pandemic, which is in some ways that helps highlight the crux of who we are as healthcare professionals, can really affect one's professional identity. In addition, I would argue that our learners are critical for patient care. This picture shows July 2018, a team of brand new learners. So we had new medical students, new interns, a new senior resident, and new chief resident, and myself, all on the pediatric hospital medicine wards. And I will tell you that we took better care of patients because of each and every one of these learners. they were critical to helping ask the right questions, to being able to bring the right insights. And I think that I am personally a better physician because I am surrounded by medical students, residents, fellows, nursing students, physician assistant students, pharmacy students, and other learners. Why? They are curious. They do not accept the status quo, and they always are pushing us to learn and teach more. They remind us of our own humanity, and they remind us how lucky we are to be healthcare professionals. So how do we integrate our learners into the new learning environment? I will tell you, our medical students are amazing and took it upon themselves through advocacy, service, teaching, research, and telehealth. These are some of our medical students who ran a PPE drive recently and gathered masks, sanitizers, and wipes to really improve our healthcare system. How can we help integrate learners into the new learning environment? We can create electives. Dr. Rishi Medarada has created a COVID-19 elective for medical students, graduate students, and undergraduates. We can convert prior electives into an online and virtual format. So Dr. Kim Huang has converted a wonderful elective that Dr. Charles Prober started probably 2 decades ago on physical findings, and has now converted this physical findings elective to a virtual format and is including our teaching seniors in the teaching of that. And as Dr. Bernstein recently reminded us, there are individual reading electives that we can all help guide medical students in learning about different topics, and many, many others. And I look forward to the electives that emerge through this pandemic. In addition, we can create research opportunities to engage learners, advocacy opportunities, and a huge thanks to Lisa Chamberlain and Janine Bruce, who have both created a very robust list of advocacy opportunities to engage learners, and through telehealth and other clinical opportunities. We must help learners learn and reflect on this situation. Remember, we are all role models, priming before, thinking out loud, and debriefing after. With that, I'd like to hand it over to Dr. Haley Gans, who is going to talk to us about how we optimize clinical training during this time of COVID-19.
Thank you, Becky. So this is really an important aspect of how we can continue to create a robust and rigorous learning environment. And I'd like to turn back to the Identity Forum and just highlight how our professional, how our professional and personal identities are really intertwined in our clinical experiences, and that this is all really tied in collaboration with our healthcare systems, which have been stressed a little bit at the moment with and the flexibility we need to bring all this together and create a really enduring and continued learning environment where our trainees are actually learning and developing, creating their professional identity. So it's really crucial to maintain this. Next slide. But I understand these are really exceptional times. We are really with unique challenges. We are actually practicing in a time that is new to us and is really strained. And so the care we provide, while it's it can sometimes be suboptimal. And there's a real change in our team dynamics, which has really created some additional challenges for us to continue to provide a really robust environment. And this is all in the face of reduced clinical volume, which is both a challenge, but as we will point out, an opportunity to really look at things with a new lens. Next slide. So there are particular unique teaching challenges, as some of Becky has pointed out, and I'm going to highlight some of these as we go on today, including maintaining our excellence and how we do that in the face of this. And again, as I said, the clinical caseloads that have decreased and also changed for us, and how this is actually both an opportunity and a challenge. And as Becky has already highlighted, our learners are excluded from clinical care, whether that's partial or entirely, and how do we continue to engage them in our clinical activities? And all this when our team infrastructure is changing, and how do we actually integrate sort of both physical and virtual people? And as Becky kind of mentioned, there are all these new challenges. So we're adapting to new techniques, things that we've never done before, and all during a stressful time. And so it's really important to actually highlight this and realize that also our trainees are also in the same boat where they're being stressed and put outside of their comfort zone. And we really have to take note of that for all of our people. And I really just want to point out that I hope what we will really tell you today is really how to make these opportunities and to look as this is an opportunity to look with a different lens. Next slide. So first I thought I'd start with a high level of care we provide. And this sort of goes back to what Becky was saying in terms of role modeling. We all know that we have a very high level of maintaining excellence in the care we provide. And we know too that there's been some strain on this as we know that a lot of our patients who should be coming in for medical care are not. And in addition, the ones that are here, there's some physical barriers to maybe providing the kind of care that we thought we should. So it's important to take these into consideration so that we can actually mitigate the effects of these. The importance of role modeling cannot be overemphasized, and really leading and role modeling times of uncertainty is one of the most crucial ways in which we can continue to provide a learning climate that is conducive to us all doing well. There's particular characteristics including confidence, clarity, calm, compassion, concern, caring for others, and a really transparent communication that actually lead to building trust and also influence the behavior of others. It's also important to realize that a lot of people are looking to us of how they should actually feel and also influencing their behavior. So it's important to understand our role and the people around us. The other part of just the clinical care we provide is to continue to empower and value all people on your team, even though some might not actually be physically present. And this has become more and more critical of how we interweave them into our daily clinical care and continue to empower them to be engaged. And a lot of this has to do with removing obstacles, because if people aren't feeling like they are cared for, it's really hard for them to actually engage in the clinical care. By providing the essentials, there's been an extension of meals and other essentials that our training needs. And this has been a really generous way that our hospital and our leaders can really provide some of the things we need. But it's really important to also realize, again, they're being stretched into areas that are maybe new skill sets, and we really need to provide the training that they need in order to feel comfortable in that. And Carrie will talk more about the physical and emotional well-being. And the last point is that it's really important to maintain energy, focus, and enthusiasm and show how we can actually be resilient when we are faced with a lot of the obstacles we're faced. And this may mean more frequent huddles or one-on-ones or whatever you have to do to really keep your team engaged and enthusiastic and with a positive attitude. I will point out that this also takes a toll on us. And so just to make sure you're doing your self-care, which Carrie will talk about. So we know that we've all seen a pretty dramatic and drastic change in our teams. And this has really challenged us all to really figure out how to do the new team and how to do it effectively. And one of the most important components, again, is the supervision. This continues to be really pivotal in how we deal with our teams and really guiding our trainees. And we need to continue to give them, obviously, the support they need. But we also have new opportunities. And so what this has opened up for us is that opportunities to observe in parts of the patient care that we actually weren't part of previously. And this just means, as sort of Becky was talking about, provides these like unique teachable moments where it's more like a coaching moment where you're involved in something that you haven't observed before. So you may be now having to be present for a lot of the clinical care team, the patient care. And so you're seeing things about communication that you hadn't previously seen. You can provide real-time feedback on. You can also focus on different parts of the clinical patient care because we maybe have more time. We're not so, because our, the number of patients we have that we're caring for has dropped, efficiency isn't as important. And so we can think about communication, critical thinking, the use of diagnostics and therapeutic acumen, things that we maybe didn't have the luxury to do previously. We also have to know that we have to utilize team members that are both present and virtual. And as you can see on the top of this is the hem-onc team. Now this is their afternoon rounds, and so they're in their patient care unit where some people are present and some people are virtually present. And during their morning rounds, they actually go around and see patients, and their case manager actually brings their dog so that the dog can interact with the patients, and they really love that. And you can see that on our infectious disease rounds now, we have our pharmacist who actually comes on virtually, and she's a very much part of our team, and we want to make sure that she is heard and still has her contributions to the team. So we have to be very aware that this is the way some of our teams are going to look. And so utilizing all the team members as we did before. Oh, sorry, I wasn't quite finished. And then interactions with patients and families, whether that's in the room or virtually, to remember them. Next slide. So I'm not going to spend a lot of time on telehealth because, as we said, Natalie Pagerler is going to do a whole grand rounds on this, but I did just want to point out that the WebEx has been a really nice way of bringing all our team members together, remembering that some are physical and some are virtual, and it allows us to continue family-centered rounds by either virtually bringing the family in or asking a family member to step out. And it's really nice because you can share visuals on the screen, so there's also some learning experiences that can happen that didn't used to be able to happen. On the outpatient, there's been some really innovative ways of actually using the Zoom features to have multiple interactions and allowing the clinical visits to remain dynamic, where the trainee and supervisor can be in Zoom and the family can be in and out of the virtual waiting room. So you can utilize these real-time learning opportunities to give feedback in any way you want. But also, this is the opportunity that allows a lot of the supervising physicians to see all parts of the visit and to give real-time feedback to that. There's also an observation where you can bring new learners into an observation mode. They can watch one, then they can do one while the supervisor is watching it. So there's a lot of really unique ways to continue to have dynamic clinical visits that meet everyone's learning needs. Next slide. So this creates a lot of teachable moments all the way from the pre-visit planning where you can zoom in, just have a faculty member and the trainee during visit observations. So now you're maybe virtually present for a lot of the observations that you didn't see previously, which gives you a unique lens. And you can have these during visit feedback with families while they're in the while the family's in the waiting room, you can actually have feedback in real time. Post-visit debriefs, and as Becky mentioned, these are really, really valuable and actually do give a lot of teachable moments that then the trainee can use in the next visit. And one of the challenges that we all have with this is to attempt to maintain trainee autonomy, since we're really present for a lot of the visit. And so we just encourage you to continue to think about this. Next slide. We wanted to talk about innovative ways to address the decreased patient volumes. And if you really think about it, this is really a fun and kind of unique way of dealing with this, but something that we love to do in medicine. So we can utilize the clinical care that we do have. How does the current cases that we have can be used as prototypes and can be generalizable? So for instance, if you have a community-acquired pneumonia, how can you really extend that to say, well, what does pneumonia look like when it's ventilator associated? How can we generalize this to immunocompromised hosts? So just sort of pivoting off the fact that you have a disease entity and everyone can talk about the different ways in which this can be generalizable. And then the fascination of the fast-paced information on the particular coronavirus can really teach us a lot about medicine. So sort of the breadth of material that's coming in on epidemiology, how does that apply to your field? Disease transmission, how does that relate to why some people have higher risk factors for things? Infection prevention and control. You can talk about virology or the effects of virology on your healthcare components, immunology, diagnostics, vaccinology, social determinants of health, and mental health impacts are all part of this and can be applied to our current teaching models. And one really creative thing that has been done is to extend clinical care conferences to other local hospitals. So we all have fewer cases, but can we get together and actually have virtual conferences? And actually having virtual conferences has actually allowed more people to actually extend some of the conferences that they're doing. And so we can have conferences with our colleagues at UCSF or some of the other local hospitals. And then don't forget that the trainees we do have, we need to keep them engaged. And there's lots of ways to do that, even though their patient load has actually decreased. They can actually write up all those case reports that they didn't have time to do previously, or case series. We all have pretty robust clinical conferences and libraries that we've been collecting clinical cases. So to go back to those, look at there's case series to publish, or look at there's other clinical entities that we can teach from. And it's very important also to realize that with the fast pace of how information is being shared, we can really look at evidence-based medicine and really talk about the biases that we're seeing, or the ways in which we can use new information or not use new information. And this can really be highlighted. And I just want to point out one of the recent publications that has come out with a collaboration between infectious disease and our hospital medicine colleagues. And so this is just a really great example of how this can be done. Next slide. So don't forget that this is a pandemic, and really maybe something we hope that we're never going to live through again, but we really need to be able to utilize some of the really unique real world training, such unique experiences such as obtaining an IND, understanding how policy decision making occurs using current evidence-based knowledge and other epidemiology and other things that are coming in, running drives, drive-by testing centers, donating blood, communicating our experiences broadly. So there's a lot of blogs and also listservs where we can actually benefit from each other, case reports, sharing policies and advocacy, which was discussed. And there's lots of patient registries where we're all learning from each other. Next slide. I want to highlight safety, because ensuring safety really instills confidence. And as part of your teaching role, it's really important to observe your trainees in donning and doffing and making sure they're doing it right, and how to use a mask for extended use and reuse, since we're all being masked now. So it's important to make sure that you actually go over this with your trainees. So my last thought is, once the dust settles, I know we're all very focused on what's happening now, and that's very appropriate, but I really would urge people to reflect on what innovation should remain as part of our care models. There's so many great things that we're doing now. So the advantages of telehealth, the sort of physical virtual team structure, the trainee observations during parts of the clinical interaction not previously seen, you can all be incorporated into how we do things coming up. And really don't lose sight of the new skills that we've all been stretched to learn and adopt to, and how we can actually maintain these and incorporate them. And of course, one comment that keeps coming up is all of us, while we deeply care about each other at all times, the sort of increased caring of well-being during this time should be extended to all times. And that's a good transition now to turn it over to Carrie to take us through some of that.
Thank you so much, Haley and Becky and Lisa, for inviting us to present today. It is an honor to be part of this Grand Rounds presentation. And I am here to talk about how we can support our trainees' wellness and the wellness of one another during this very challenging time. So there are many causes of healthcare provider stress that are related to COVID that we should be aware of. So first of all, there is uncertainty. None of us know how long this will go on. Is the world changed forever? There's uncertainty about whether we're managing this right, and are we making the right decisions? Are we adequately protected as healthcare providers? And then we have fears. We have fears of getting sick ourselves, of our loved ones getting sick, and of us accidentally transmitting disease to other people. We may have anger that others may not be following the social distancing protocols and recommendations, and anger that leaders may not be acting as quickly or in the way that we think they should. We also may feel loneliness or isolation, especially if our loved ones are far away or if we live alone. We may be feeling grief and we're grieving the life that we wish we had, the life that we used to have, and things are changing and we can't control that. And there's a concept called sideline guilt. And this is the concept where if we are not on the front lines, we may feel guilty that we're not contributing in the way that we think we should. And that may be because we ourselves are sick and needing quarantine, or we just weren't assigned to the front lines. There also can be a guilt related to being here in an area that's not heavily affected with COVID, while we see parts of the country and parts of the world that are much more severely affected. And then some of us may be facing anxiety and depression as well. Next slide. I thought it would be helpful to review Maslow's hierarchy of needs, which describes the needs that we as human beings have that allow us to feel secure and motivated. Starting at the bottom level, these are the most basic human needs that we have: food, shelter, and water. Beyond that, we need safety and security. And at the beginning of this pandemic, it felt to some of us that we were being thrown into the front lines of battle without proper armor. And so our safety and security may have felt threatened, and it may still feel threatened at this time. At the next level, we need relationships and connections, and these have also been disrupted, and we are not able to see our loved ones in the way that we'd like to. We're not able to see our friends and our colleagues either in the same way that we'd like to. So this pandemic has really affected the bottom three levels so significantly that many of us are not operating at the highest levels of motivation right now. Next slide. Next slide. In terms of specific sources of COVID-related anxiety, I'd like to point to an article done by Tate Shanafelt and his group here at Stanford, where they interviewed various healthcare providers here at Stanford to understand the sources of stress and anxiety. And a lot of these are ones I've already talked about, with basic needs, access to PPE, but in addition to that, access to childcare if we have children, and worries about what will happen to our families if we become sick. Will they be cared for and provided for in the way that they need to be? There's also fears about being competent if we are asked to cover areas that we're not used to covering, and concerns that we may not have the up-to-date information that we need. Next slide. This was a study done out of China where they surveyed over 1,200 healthcare workers in the era of COVID to understand how well-being was affected. And so of the 1,200 healthcare workers surveyed, 71% reported psychological distress, 51% reported depression, 44% reported anxiety, and 34% reported insomnia. And these are data that I suspect are very similar here, and many of us are feeling a lot of these same symptoms and have stress, trauma, and anxiety related to this epidemic. Next slide. Bringing it back to the professional identity formation model, there are several areas that Becky already mentioned that are being disrupted right now and that affect our identity, including feeling isolated, not being able to connect with our friends and loved ones, and having disruptions into our routines and rituals of everyday life, as well as the really powerful symbols that Becky mentioned, the graduations that we're looking forward to, and the white coat ceremonies and other things that are really important in medicine, and those are being disrupted right now, and that is very difficult. Next slide. But we have hope, and there are ways that we can be positive in this very challenging time. There are mediating factors, which include the use of reflection and modifying our self-assessment. And we can manage our thoughts and feelings and reframe them to be positive and productive. We can also recognize that we are incredibly valued by our society for the work that we do in caring for others during this challenging time. Next slide. So we'll transition to talking about how we can manage stress and anxiety in ourselves and in others. Next slide. And it can be helpful to look at other areas of literature for data on how to deal with trauma and stress. And what field faces this more than any is the military and soldiers. And there was this beautiful letter that was published recently by a soldier who wrote a letter to his friend who is a physician working in the emergency department in New York on the front lines. And he shared his tips for dealing with a crisis from a soldier's perspective. And I pulled out some of my favorite tips here. First is find a battle buddy. And I think this is hugely important because we don't want anyone to feel alone during this time. And so we encourage trainees and we encourage faculty to make sure that you are looking out for one another, make sure that everyone has someone that is checking in on them, both to provide personal support as well as support if someone were to become sick. Second is to make time to rest. We need to rest so that we can venture on and carry on during this challenging time. This is a marathon, it is not a sprint. We need to take time to huddle to make sure that we are on the same page and we are working together to conquer this disease. We need to engage everyone and make sure that everyone has a role. And this has been a real challenge as many of our trainees and many of our faculty are working remotely and are not engaged in the same way that they used to be. But we are working hard to make sure that people are involved with remote teaching and other ways that people can be actively engaged in this time. We need to plan and prepare for what we don't expect will happen. We need to recognize that decisions may need to be made quickly and they will not always be perfect. We need to encourage adaptation quickly. And we as leaders should take time to praise our team at every opportunity and thank them for the hard work that they're doing. This is critically important. We also should recognize that leaders can't have a bad day. And we as faculty members and we as leaders in other parts of the institution, we have to be strong and we have to be sound and solid so that we can support our trainees and others that we work with. We can also learn from, sorry, one more on that slide, thanks Becky. We can also learn from soldiers about how they deal with stress. And there was a study of veterans that had post-traumatic stress that showed that they had considerable post-traumatic growth, specifically around the areas of recognizing changing priorities and about what is important in life and being able to embrace every day. And the specific mediating factors that helped the post-traumatic growth included having gratitude, having purpose in life, having spirituality, and social connectedness. Next slide. So I'd like to briefly review the literature on how we can support wellness and resilience during this time. And there are three main themes. One is finding meaning, second is community, and third is self-care. In terms of finding meaning, really the foundation of this in medicine has been the doctor-patient relationship and time at the bedside. And this has been disrupted because we are not at the bedside in the way that we used to be, and we are needing to learn how do we foster the doctor-patient relationship through telehealth, and that is a new challenge. We can also find meaning in knowing that we are serving our country during this time, and that is a very important role that we have. Trainees can find meaning by taking on increasing responsibility and being more independent. We can show gratitude, and some of us look to spirituality or religion to help us find meaning in our role as healthcare providers. Next slide. In terms of community, we all need to have connections and we should support one another and look to our home networks as well for community. We also need to foster teamwork and show respect and support for our multidisciplinary team. This is hugely important to being able to work together and get this disease under control. It is also helpful if we have things like process groups or reflection times to work through the various feelings and emotions that we have. And we can use things like humor, distraction, and time with loved ones as well. Next slide. There are many methods that we can use to manage stress and help with our own self-care. So the fundamentals include good sleep, nutrition, and exercise. There are also many ways that we can relax, including deep breathing exercises. I recently learned of one called tactical breathing. Mindfulness and self-compassion have evidence behind them, and they have been shown to decrease stress levels. We can also use music and hobbies as ways to manage our stress. And then there's evidence that shows that gratitude can also be helpful. We can take time to notice the good, the beautiful, and all the wonderful things that are going on as well. And then we can also focus on postponing our stress, and this can be very effective. It is normal for us to have some degree of worry and stress during this time, and we shouldn't pretend we don't. but we can put a time limit on that. So it may be okay to say, I am going to spend 30 minutes thinking about all of the worst case scenarios and what ifs and what might happen, and let all those worries come over you so you can work through them, and then set that aside and say, now I'm going to think positively and productively and move forward from here. And that can be very effective. We also should limit our consumption of news and social media. There was a study done after the Boston Marathon bombing that showed that people who had heavy consumption of social media and news in the week following the bombing had higher stress levels than those who actually witnessed the bombing themselves. Next slide. So there are many ways that we can provide self-care to ourselves and relax and be mindful. And I thought this was just a fun image to show all of the positive ways that we can take care of ourselves. Next slide. And it's important for us to recognize what is normal worry and stress, which happens to all of us and is what we should expect, and what is excessive worry. So normal worry is something that can be productive, can help you actually work through problems and get things done. Excessive worry gets in the way of the things that you're trying to get done and can actually be destructive. And you'll know that you're experiencing excessive worry if you have interrupted sleep, intrusive thoughts, or feelings of hopelessness, depression, or suicidality. And if you have any of those symptoms, we want to get you connected right away. We've got fabulous resources here at Stanford, including 24/7 access to WellConnect and confidential mental health services, and also the Physician Resource Network that provides peer-to-peer support as well. Next slide. So what can our organization do, and what can we as leaders do to support our trainees and support one another? And going back to Tate Shanafelt's study, there were a few themes that came out. And the first was listening and validating those around us and the feelings that they're experiencing. One of the concepts we can look to is psychological first aid, which has been recommended by the World Health Organization and is a tool that anyone can learn. And the tenets include providing a safe environment for others to talk, listening and validating their reactions, and brainstorming positive ways that they can deal with their reactions. This study also found that we need to provide proper protection, training and support, personal support, as well as benefits and resources to provide for our healthcare providers and their families, even if they become sick. Next slide. I'd like to highlight some examples from what we're doing in our department, and we have some amazing chief residents right now, Danielle Kirky, Minnie Dasgupta, and Jake Weatherly, who have been instrumental in leading our pediatric residents through this challenging time. They have been sending out daily COVID emails to provide information and humor and uplifting comments as well. They've been holding weekly town halls to answer questions and also provide in-person information, or I should say Zoom information. They've also advocated really hard for our residents to continue to be involved in clinical care, and this has been challenging because it's been hard to know how much to involve trainees in the COVID pandemic. They've also developed a website for remote learning activities so that our learners at home can do self-directed learning, and both our residents, our fellows, and our medical students have been accessing that. And they've also developed a website of community resources that our healthcare providers have access to and benefits to help them through this time. Within the fellowship, we have fellow town halls that are happening weekly, also to provide information to the fellows and provide support as well. Next slide. So what can individuals do to support their own wellness and take care of themselves? There are many, many options, and I thought this was a fun demonstration of the ways that we can either pick up old hobbies that we had or maybe learn some new hobbies during this time. And a lot of creativity can come from times of crisis, and so I encourage each of you to think creatively about what you can learn and how you can grow during this time. So. Thank you very much. I'll pass it back to Becky to talk about national education landscape and guidelines.
Thank you, Carrie. Finally, we'd like to talk about the national education landscape and guidelines. As noted before, there are a number of challenges affecting our national landscape. These include clinical challenges, educational challenges, worries about graduation, residency, fellowship, and job applications, and how do you start new programs in new locations, and the aforementioned isolation, anxiety, and burnout. The AAMC and LCME, which oversee medical school education, have recommended pulling medical students from the learning environment at the beginning of the COVID pandemic. And now they have recently stated that for medical schools in locales where there is significant, active, current, or anticipated COVID-19 community spread, and/or limited availability of PPE, and/or limited availability of COVID-19 testing, that their guidance remains that unless there are critical healthcare workforce needs locally, they strongly suggest that medical students not be involved in direct patient care activities. They have allowed flexibility in clinical requirements, and they are allowing medical students to graduate early to help with the pandemic. Meanwhile, the ACGME, which accredits residencies and fellowship programs, have relaxed clinical rotation requirements. They've put emphasis on the program director and the clinical competency committee to determine readiness for graduation. The ACGME has advocated for learner safety, learner leaves of absence, modified training, and continued work hour limits during this pandemic. And they, unlike the AAMC, have actually discouraged having residents start early, because as we are now currently in a time-based training program, it would mean that we would be having a number of residents graduating early from programs 3 to 5 years from now. The American Board of Pediatrics and other medical boards for other specialties have been more flexible, allowing leave for illness due to the pandemic. And they have also reiterated that the program director and CCC determine readiness for graduation. Finally, we've seen a number of national collaborations emerge. The Association of Pediatric Program Directors has been hosting virtual cafes daily in order to bring program leadership together to foster collaboration. The APPD and the Council of Pediatric Specialties has brought together town halls for fellows nationally. And a number of organizations are collaborating to improve the residency application process. These were collaborations that were happening before COVID, but have been intensified because we may need to be thinking about a virtual application season. Finally, we've seen a number of individual programs, including a number of programs across Stanford, inviting other learners to join their teaching sessions. So to take our take-home points, really, we want to emphasize the role that professional identity formation plays in all of our development. As we said, this is a lifelong process that through the COVID-19 pandemic, we are seeing both challenges, but also opportunities for us to further understand and explore who we are as physicians and healthcare professionals, and who we are in our personal identities. And that all of you play a critical role in these medical education interventions that we can do in order to help foster professional identity formation in our residents, fellows, students, postdocs, and other learners. We want to recognize the multiple factors that contribute to professional identity formation and those that may need to be modified during COVID-19. To continue teaching and role modeling, we need to create new roles and activities for learners and faculty in clinical care and support research efforts as possible. We need to provide emotional support and remind learners that they are important to patient care and to all of our learning. We need to recognize people's efforts publicly and personally, and remember to take care of yourself so you can take care of others. And finally, we'd like to end with this quote. This was recently published by Dr. Sarah Pavitt and Amanda Sandoval-Karamian, who are two of our Stanford Child Neurology PGY5s. And they wrote this in a recently published blog. On March 16th, 2020, our traditions needed to change abruptly, as it was learned it was no longer safe to gather in groups due to the COVID-19 pandemic. As a program, we quickly came together to evaluate different possibilities for patient care in the days and weeks to come. However, in the back of our minds, there was a consistent draw to the significant impact this pandemic could have on our education. Although our clinical work is essential during this crisis, we are still trainees and our education remains a priority. As residency programs across the country grapple with these same limitations, we hope to inspire you to continue formal resident learning in any format. It will not be perfect, but it will be powerful. As frontline providers and trainees, we still need these opportunities. And with that, we'd like to give huge thanks to all of our learners and to all of our faculty and staff who have been extraordinary. And while we're taking questions, I will scroll through the references, which includes some links to how to do Zoom and Poll Everywhere, as I saw there were questions about that as well. And with that, we'd like to turn over to Lisa for questions.
Wonderful. Wow. I know everyone's joining me in saying thank you very much to all three of you for such a broad conversation, all the different levels of education. It was really very impressive. So we do have some questions. Looking at the time, it is 9 o'clock. So for those who have clinical obligations and need to get off, we understand, but there are plenty of people, my goodness, hundreds of people who I think might enjoy staying around and getting more of your insights. So yes, to your point, Becky, quickly, a lot of appreciation about the technical capacities of Zoom. Some people not realizing you could do Poll Everywhere and video conferencing, wanting more information about how you can do the groups and breakouts and stuff like that. So I think maybe those are things you can answer directly to individuals, since I think that might require some sharing later on. But it sounds like lots of resources in your references there as well. So moving on to some of the meatier questions, there's a recent proposal by Bachman and Sharfstein, a proposal where first-year medical students would spend a year doing COVID national service. Wondering if you'd seen that, what your thoughts are about that, and how it might address some of the medical education opportunities that they are otherwise lacking.
Yeah, I would love to have this discussion amongst many medical educators and hear many perspectives. I did have the opportunity to read that piece and found it very interesting and provocative. I think it's great for us to think about our current system, and are there opportunities we could really capitalize on to learn from? Are there, and simultaneously we have to think about our current system and can we accommodate new learners? I think I would take their argument and extend it, thinking that if learners wanted to take a gap year, this would be a wonderful opportunity to explore opportunities in public health, but simultaneously to explore other opportunities in research, in teaching, in other ways of engaging with the healthcare system. And so I might just extend what they were saying to make it a bit broader. Meanwhile, I don't know if our medical systems can fully sustain a gap of a year missing medical students. As I said, I actually think they're crucial to all of our learning, and we miss having them on the wards right now and look forward to when they're integrated back on the wards with us. And so I think there's opportunities to think about multiple possibilities that learners could take in this coming year. And I'd invite Carrie and Haley to add in any comments they would have as well.
I'll just add that I think all of us as healthcare providers should learn to manage COVID. And as a result, we all need to be engaged in it. So it's a little bit of a balance between preserving numbers of people exposed, but also making sure that we are all competent and capable of dealing with this healthcare crisis and assessing patients who might have COVID. So I would hate to take all of the COVID cases and funnel them into a narrow pool of physicians who may not be available down the line when this needs to be addressed in the future.
Yeah, and I just want to point out, and I was hoping that we were able to show this today, is really how to integrate this kind of knowledge base into our systems, and that this should be something that we do ongoing. This is a fascinating sort of medical knowledge foray, and that is something that we can bring forward to all of our fields and really learn from it. So I am in favor, as Carrie just said, to integrate it.
Wonderful. Haley, I think this question is most probably addressed to you. Can you address the consequences down the road when a generation of medical trainees must learn medicine without having as much hands-on experience?
Yeah, thank you for that. And I think we're appreciating some of the challenges that we have to not allowing some of our trainees to be in physical contact. And so there are, as was mentioned, and this really doesn't take the place, but it can do stuff. So there's a lot of sim you can do in terms of how you can actually train people in some of the physical training that we need to do, all the way from, you know, how to spot a murmur, things like that. There are ways of actually showing, so you could broadcast the otoscopic or pharynx findings in and out of a room, things like that. So there are ways to sort of mitigate that, but we realize that doesn't always come from a hands-on experience. I do want to point out that a lot of our trainees are still doing hands-on. So, I mean, we are including them where they have to be included. They're part of our critical, you know, frontline people, so they aren't missing out on that. The other part of this that I would just like to point out is that we are all lifelong learners. And so we realize that they're opting or stepping out, or it's not their own option, but at a very critical time right now, and maybe in part of their training. But we're going to be in this for the rest of our lives. And so hopefully that's a really huge time in which to acquire some of this knowledge set. So I don't think overall that that's actually going to have a huge impact on their careers.
Okay, great. Shifting a little bit to some economic and healthcare field challenges, what recommendations do we have about graduating residents who are going to be looking for jobs with healthcare systems on hiring freezes and in contraction? Thoughts about that?
This is a real worry of ours nationally. We've been having conversations both locally and nationally. And I will say we found similar concerns during the 2008 and 2009 recession. I think during that time, many people did take moonlighting and other positions that were available because, as you stated, Lisa, there are a number of hiring freezes right now. Though we did see a year later that many of those faculty and other positions did become available again. And so it's our hope that will become possible again here. Meanwhile, I would also say that Mary Leonard, our chair, and I know the chairs across all of Stanford are being really thoughtful about which searches do still need to continue even during this time of financial hardship due to COVID. And so I really appreciate how thoughtful they are being in both the skills and the people that we need here at Stanford.
Great. All right, Carrie, I'm coming your way. Catastrophic thinking is contagious. That opening line caught my eye. How do you balance self-care that can come across as hard-heartedness with compassion that can lead to transferring another's anxiety and fear? So where's that balance point?
Absolutely. I think this is a huge challenge, and we do need to both care for ourselves, which sometimes feels like a selfish act, but is important and essential. But we also need to care for others, and we have to make sure that we're not too inwardly focused during this time, both because others need us and because it's not good for us to be overly inwardly focused. It's a little bit like the concept on an airplane where you put your own face mask on first and then you help the person next to you. And we should be doing that as well. We need to make sure that we are rested, we are fed, and then we need to look to our neighbors, the people in our community and our colleagues here in the institution, and check in to see how they're doing as well. So I really feel this is a time of interdependence where we need each other and we need to help one another out through this time. But it is a delicate balance.
Okay, and a more concrete kind of wellness question comes saying childcare is killing us. Summer camps just got canceled. How am I supposed to be good teachers and be a good doctor when I'm also doubling as a first grade and preschool teacher to my own kids? So just this clash in our family lives in terms of how do we support everyone's needs. And I know people are doing a lot around that. Any thoughts around specifically summer or more extended support for our faculty struggling with this?
It's a great question. I know Tate Schoenfeld's group has done a lot to try and develop new resources in the community. And there was just a list of new childcare centers that came out about a week ago. I can send that to whoever is interested if you shoot me an email. I know I personally have been challenged by this, and I've had children crawling over me during Zoom calls at home and such. So I think many of us are in this together and understanding each other's challenges. I personally just signed my preschooler up for a new childcare preschool that is for healthcare providers. And we're starting there next week. It's in Menlo Park. If anyone is interested, let me know and I'll send you the information, but it's for 3 to 12-year-olds. And you have to be a first-line responder to access it.
Oh, well, it's a great resource. Thank you.
Yes.
Okay. Seeing other people want to learn how to do polls on Zoom. If people are interested in learning some concrete skills around how do you set up that group chat and how do you do polls on Zoom, please enter that interest and your email into our chat boxes. We will either connect you with online YouTube stuff or maybe a workshops coming up, or I'm sure between these three it's covered somewhere. But I know those are real practical tools, and want to make sure your opportunities are there for you for that. Want to end on kind of an optimistic question. This one from me. This is obviously a very challenging time, but it's really an opportunity to disrupt and do things differently. So let's fast forward 2 years. How did things look different? So we've settled into our post-COVID world. What are you most excited about? What change has come from this that you think strengthens our educational opportunities and creates even better doctors because we've been through this together? So let whoever wants to go first.
I think there's so many possibilities of how this is going to make our educational system better. I think this incredible focus on professional and personal identity formation and this ability to have these really honest discussions about who are we and where are we going and what's influencing that has really been opened up by this pandemic. I also think that our educational resources, we've found ways of being more inclusive and building an environment that is more inclusive to those with disabilities and those who are in other locations, because we are across many sites. And so I actually think that we're just beginning to learn about how interactive we can be over video conferencing. And we are seeing more and more learners share. And then nationally, I will say we have seen a level of collaboration here that I haven't, we've seen amazing collaboration in the past, I should say, but this has just been incredible with people really helping one another develop educational content, to develop better clinical abilities and settings. And I think it's been an incredible time that I really hope that we continue to see this national collaboration.
Yeah, and I would agree with all of those points. What I'm really excited about is that sort of collaborative way of doing science, which is not something that we're used to doing, and really trying to get everyone to sort of the same time zone so that we could all actually work from that point onward is very exciting in our field. And I love the fact that we can do that in real time. And this idea that you know, I tried to do a national curriculum for Pete's ID so far ago, and then to hear that like cardiology got it up and running in a week was amazing. For cardiologists, you know, just all poured these different, you know, they just did their own phone recordings and put their slides up is just an amazing. So that integration of all of our technology into our learning and the way we do medicine, I think I hope we don't go back to sort of the way that we've done things.
I totally sense that as well. Haley, Carrie, any last thoughts?
Well, you know, we have wanted to use more technology in our residency program for a while. As you know, we have residents that are spread all over the peninsula, down at Valley, down at Sunnyvale, at Gardner, and here at the main hospital. And so we were fast forwarded into doing that, and it's been fabulous. And we have people zooming in from all of those locations into our morning reports and noon conferences every day. And I hope that that is something that we will sustain after this pandemic is over, bringing people together so they don't feel that they're away at a different site as much, but rather still together learning. So.
Yeah. Right. And one of our astute listeners chimed in that 2 years from now, hopefully we'll have a different perspective on vaccines. The anti-vax voice had grown, and we are now all desperately, hoping for a vaccine to come forward. And so hopefully that will shift some public perspective on that. With that, I will conclude. Thank you to everyone who's entered your name in terms of being interested in learning more about the technological skills that we can gain. And again, thank you all very much for the time and energy and effort you put into this really expanding talk. So thank you guys very much. And thank you to all of our viewers. We will see you next Friday.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.